All right, so the subject of my, my second talk will be a little bit different. You're not going to have a deep sequencing and DNA and mRNA things, but it's going to be a little bit more practical. And one thing that you're going to hear 100 times till you get sick of it, because that's basically the basic message when you get the results of the core needle biopsies, is clinical radiological, pathological radiological correlation. I mean, this is imperative. You can't do that when you do a core biopsy without correlating with the radiology, what you're going to do next with the patient, because it's of critical importance. So a pathologist can't do by itself in a box, and the clinician can do with just by looking at the radiology or the pathology. You have to put the whole picture together and do the pathological correlation, pathological radiological correlation, and then make a decision if you're going to re-excise or not, depending on the result you got in the core biopsy. So what do we do with a core biopsy? Basically, we sample the imaging abnormality, and as pathologists, when we get the tissue, we hope that the core biopsy that you guys send us, it's actually representative of the tissue that would be obtained in an excision specimen. And it has to be adequate tissue. Of course, you're never going to hear a pathologist complaining about giving him more tissue. And it has to be adequate to make a diagnosis, if possible, and then do further immunohistochemical studies if that's necessary, and to determine different various prognostic or predictive factors based on the core biopsy results. Now, one problem with pathology that will never be resolved is it's interpreted by humans, although artificial, as a parenthesis, artificial intelligence is coming very, very fast in the pathology and radiology world. So there's inter-observer variability. What I mean by inter-observer variability is that if you take a sample and you give it to 10 different pathologists, you're not going to get one answer. You may get 2 answers, or even more, pathetically more than 2 answers. So the reproducibility of diagnosis when there is atypia remains an area of potential for overall quality improvement in breast pathology and other subfields of pathology, that irrespective of the specimen, either it's a core biopsy, a needle core biopsy, or an excisional biopsy. Now, the evidence base to guide management on lesions that we get as atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, that we detect on core needle biopsy, they're not very well developed. And the reason is that the opportunity for detection and diagnosis of these non-malignant breast lesions, ADH, ALH, LCIS, has actually changed dramatically the last 3 decades or so. So that leads to some kind of uncertainty regarding the optimal management of these lesions for several reasons. There is the published literature, surprisingly, is actually almost entirely of small single institution retrospective studies. We don't have very good prospective studies, and there's a lack of clear criteria for in the excision. And that we don't have a very good long-term follow-up for lesions that are not excised. So there's a lot of problems in the medical literature regarding these areas, and there's a lot of opportunities for further research. Now, there are a few studies that they have very good follow-up data for lesions that are not excised, and they're very valuable. However, you have to be, when you study all these papers, you have to be very careful, because there's selection bias in these studies. The length of follow-up remains a concern about these studies. There's many of these studies that don't have a good pathological, radiological correlation. So you have to read all these studies with a grain of salt and be very careful actually to read carefully the methods, because that will actually determine if this paper is worth reading or not. Now, one of the most problematic areas when we have all this literature is that many of these studies lack the most crucial finding, meaning radiological pathological correlation. And why that's important is because they give you the study retrospectively, and they say the upgrade percentage was X or Y, but many of these lesions, they will have been excised anyway based on clinical or radiological findings. So this should be taken out of the equation when you study statistically these core needle biopsies for the possibility of upgrade. this is very crucial in all this study, radiological pathological correlation. And the other thing is that the criteria for diagnosis of ADH, ALH, or LCIS actually were not established in core needle biopsy, were actually established in excisional, in open biopsies, largely before the mammographic area. So it's more difficult because we set up the specific criteria, but this was based on different samples. Now, the other thing is the risk of upgrade is going to be defined depending on the specialty that the studies are coming from. For example, the radiology literature is defined a little bit different. Everything that has a risk more than 3% immediately will be an upgrade, where in pathology literature, or surgical literature, is defined a little bit different with a relative risk of more than 4. So there is a little bit different definitional problems what we define as an upgrade. So some people define upgrade if you find a carcinoma in the excised specimen. Some other literature define an upgrade if there's a worse lesion on excision. And what I mean by that, if you get a diagnosis of flat epithelial atypia in core needle biopsy, and then you get a diagnosis of atypical ductal hyperplasia on the excision, some studies will define this as an upgrade, despite the fact there is no invasive carcinoma there. And again, studies have defined different histologic findings as high-risk regions, and radiology, as I said, literature or pathology literature, the definition is a little bit different. So you can see already from a few slides that there's a lot of problematic areas assessing this study. Now, the non-malignant breast lesions that are frequently associated with upgrades to carcinoma and excision, and we're going to talk all of these, is of course atypical ductal hyperplasia, where the upgrade is about 20 to 30%. Then you have ALH with the upgrade of 0 to 10%, LCIS 0 to 10%, flat epithelial atypia, papilloma, radioscalar, and Mucocele-like lesions. So we're going to talk about all these lesions and what is the upgrade, what data we have regarding the chances of upgrade, and what is their current management recommendations. So atypical ductal hyperplasia, how do we define? It's an atypical intraductal epithelial proliferation, but that has some, but not all the features that are required for the diagnosis of low-grade DCIS. And it's a quantitative diagnosis. What I mean by that is qualitatively, morphologically, defines the criteria for low-grade DCIS, but it's just not enough. And in the next slide, I'll tell you what do we mean by not enough. So it's, and that makes it a little bit problematic because it's a quantitative problem in relation with the low-grade DCIS. We make the diagnosis based on a combination of cytological and architectural factors, and the expected rate of diagnosis of ADH on core needle biopsy in a regular breast pathology service is about 3% of the core biopsies. So it's a usable diagnosis because this avoids, if you call all the ADHs low-grade DCIS, it's going to be a huge overtreatment because mastectomy, bilateral mastectomy, or lumpectomy, etc. Because it's a useful term because some patients, they have a limited extent and there's no residual disease in the excision specimen, so ADH will fit very well instead of labeling all these patients with low-grade DCIS, which is just a minimum amount of tumor. Now, if you actually see the studies of atypical ductal hyperplasia that you were diagnosed on core biopsy, and then what was the upgrade, you actually see some percentages from 28% to 56% of cases. But surprisingly, the studies have showed such a high upgrade to carcinoma that it's not very tight pathological radiological correlation, and not surprisingly, the upgrade rates were higher when samples were taken with a 14 gauge ultrasound-guided core needle biopsy, because the tissue, of course, it's smaller. So, in more careful design studies, where is a strict radiological pathological correlation, the upgrade is in the range of about 15, 20, 25%. And this is various studies all over the years, the number of patients, about 1,300, the meta-analysis. So the rate of the upgrade percentage was about 20%. So the upgrade for 848 has not actually been shown to be significantly lower when you use larger 9-gauge versus 11-gauge vacuum-assisted stereotactic core biopsy devices. And actually the pattern of atypia and the number of foci that you see in the core needle biopsy may actually influence the likelihood of upgrading at excision. It kind of makes sense because it's a quantitative. You have quite a few. The likelihood to get DCIS in the excision specimen is higher. So a few people have suggested actually that a subset of these patients may actually have close surveillance. People with very focal ADH, you get a lot of core biopsies and have a very focal ADH, or you have absence of residual calcification on post-core needle biopsy mammogram. Some people, I mean, it's not a common practice here, but some people suggested that these patients actually may have a close surveillance rather than get an excision. And this is how it's looked under the microscope. Atypical ductal hyperplasia basically looks like DCIS. It's very uniform, monomorphous, bridging, cribiform kind of architecture, but it's just not enough to call it low-grade as DCIS. So it's a quantitative assessment. And the diagnosis of low-grade DCIS is usually restricted when you have at least 2 duct spaces or an area of more than 2 millimeters in extent to move it from ADH to a low-grade DCIS. I mean, nothing's black and white in pathology, and otherwise a computer could do that. There's a lot of gray in many of the diagnoses. So there are borderline cases, and some experts favor reporting these core needle biopsies as a typical intraductal proliferative lesion, and then they recommend an excisional biopsy. Now, people attempted, there are studies there, to actually predict with greater reliability which actually patients with ADH might actually be spared an excisional biopsy. And this is a study by Course and colleagues from the United States, I believe, in Buffalo. They wanted to calculate the likelihood of upgrading by using about 200 patients that consecutive cases of ADH on core needle biopsy, and then they have an overall upgrade about 28%. So they came with this kind of a nomogram that takes a little bit different factors in place, the age, the menopause status, hormonal therapy, et cetera, and they have a scoring system, and they were trying to calculate if some of these patients with ADH could be spared an excision. However, we have to be mindful of that. The fact is, patients that they were least likely to experience an upgrade, they still had up to 80% rate of upgraded carcinoma, which is kind of a pretty significant number. So at the current time, based on the rate of underestimation of DCIS in patients with been diagnosed with ADH on core needle biopsy, most experts actually recommend excision for all diagnosis of ADH on core needle biopsy. Moving on to atypical lobular hyperplasia, what is it? It's a proliferation of monomorphic epithelial cells. They have cellular adhesion, and the reason for that is because they lack EAT adherence, as I said in my previous talk. And the expand of the terminal duct unit is less than 50%. That's kind of a definition of ALH. It's usually an incidental finding, and the statistics in the busy pathology department is usually less than 1% on core needle biopsy. Because the incidental findings are very rarely associated with micro calcifications. Now, some studies have reported upgrades up to 20% for ALH. However, again, these studies are not very reliable because there's not careful radiological pathological correlation. And actually, in the studies that the ALH was incidental, they were not targeting calcifications or anything like that, the upgrade was 1 to 2%. So 1 or 2 patients in 100 will have an upgrade of the diagnosed ALH. So many institutions now recommend observation with patients with incidental ALH diagnosed on core needle biopsy that they lack further indications for excision. LCIS is basically an atypical epithelial proliferation that is cytologic, actually looks exactly like ALH, but the expansion of the terminal duct lobular unit is more than 50%. LCIS about 1% of core needle biopsy performed following mammography. And you see a lot of different rates in the literature, but again, all these kind of numbers is in studies that do not have a pretty strict radiological pathological correlation. It's often an incidental finding, and maybe, especially on the variants of LCIS, maybe targeted lesion associated with microcalcification, but most of them are not. So In studies where they have a very careful radiological pathological correlation, the upgrade was much lower for LCIS that was incidental rather than being a radiographic target, which kind of makes sense. It was about less than 40%. You see here 33%, but this study is just not very good studies. So I would say the incidental LCIS was about 4% of upgrading. So 4 in 100 patients would be upgraded. 96% of cases would not, based on the study. So there are actually a few studies that they reported patients, the follow-up patients with that they were diagnosed with ALH or LCIS on core needle biopsy, and they have a very clinical radiological close follow-up to see what's the chances of progressing to develop a carcinoma after 3-4 years. And actually, the number was about 2%. So patients were diagnosed with ALH or LCIS. We did nothing about them, and then we're just following them up. The possibility of developing carcinoma the next 5 years was about 2%. And these are pretty solid studies. So, for incidental classic LCIS or core needle biopsy that they don't have any other indications for excision, observation may be appropriate. However, bear in mind that the National Comprehensive Cancer Network guidelines continues to recommend surgical excision for LCIS that diagnosed on core needle biopsy. However, there are definitely some kind of over treatment here. The term lobular neoplasia may actually be used collectively if you're referring to ALH or LCIS. However, when you get a LCIS that is not the ordinary type, it's either the pleomorphic LCIS or florid LCIS with comedo necrosis, then what I told you before doesn't apply. So variants of LCIS, they should be excised. And the term lobular neoplasia, not otherwise specified, should not be used for variants of LCIS, comedo necrosis, etc. The likelihood of upgrade is actually much higher. Other problematic lesions that you may encounter in your practice, and you do a core needle biopsy and you get a diagnosis of flat epithelial atypia, or benign papillomas, radial scar, or Mucocele-like lesions. The optimal management remains controversial. That's the reality. The upgrade rates, they vary quite significantly, and that depends if there's a pretty good radiological, pathological correlation. So flat epithelial atypia. So the term flat epithelial atypia is used to encompass columnar cell change and columnar cell hyperplasia with nuclear atypia. You see here there's overcrowding, there's a loss of polarity. So this is what we call flat epithelial atypia. And microcalcifications are frequently present in association with FEA, and most of the cases are actually the imaging target. Now, there's a potential relationship between flat epithelial atypia, atypical hyperplasia, low-grade carcinoma. We know that all these have the same molecular alteration, and they actually flat epithelial atypia may be a non-obligate precursor in the low-grade neoplasia pathway. So, let's say you get a diagnosis of flat epithelial atypia alone on the core needle biopsy. What is the possibility of upgrade to carcinoma on a subsequent excision? So the studies vary. You have studies from 50% to 67%. Again, some of these studies that do not have a very good radiological pathological correlation. And I will say in the most recent studies, particularly because they're the target of microcalcifications, if all the microcalcifications have been removed, so presumably you could assume that this is the whole lesion that you see in the core biopsy. The upgrade rates were actually even lower, ranging about 0 to 7%. And actually in this study, a 5-year study, they have 50 cases of pure flat epithelial atypia, which they didn't go back. They just observed the patient, and actually no patient developed carcinoma with a median follow-up of 5 years. And presumably all the microcalcifications had been removed with a core needle biopsy. So when all microcalcifications are removed, the upgrades are very low, and you can offer patients observation as an alternative to surgery. However, again, radiological pathological correlation it's imperative, but in the absence of any other indications for excision, actually observation may be an acceptable management strategy in patients with flat epithelial tibia. So papilloma, we have a spectrum of morphology. We have benign intraductal papilloma, papillomas involved by ADH or DCIS, encapsulated and solid papillary carcinomas. These are easy. They have to be excised. So what do we do with the benign intraductal papilloma, which is the problematic issue in terms of management? If you find a single benign radiological concordant papilloma, do you go back or you do not? So there was this paper, meta-analysis of 34 study. There's overall there was a pool underestimation rate of malignancy 15.7%. However, if you actually look pretty carefully on this paper, they pulled together totally benign papillomas with atypia, so the data are not very reliable. In the benign papillomas, the upgrade was about 7%, atypical lesions was much higher as expected. So this is a meta-analysis about benign papilloma, and you see here that combining all these, a lot of studies, there's a lot of numbers here. On the basis, some of the studies on the basis of an abscess of upgrades and papillomas that were incidental, were benign, they were less than 2 millimeters, the so-called micropapilloma. Some people actually recommend radiologic follow-up for these patients rather than excision. This was a most recent study that included 146 benign papillomas that were measuring less than 15 millimeter. And in this study, they did not find a size threshold below where there were no upgrades. So, I mean, the question is there a size threshold that is pretty safe to follow up these patients? In this study, they said there was no a safe size. However, it is difficult, first of all, to determine the size, either in pathology or in radiology, because of the irregular peripheral contours. And in this study, they actually combined benign papillomas with atypia, so that was kind of a problematic. So overall, if you actually assess the good studies with a good radiological pathological correlation, the rate of developing carcinoma within 3 to 5 years, if you get a papilloma diagnosis, was about 0 to 4%. And actually, some of these cases, they didn't actually progress to carcinoma. They probably had already carcinoma that was missed, because if you actually read carefully, the interval of the coordinated biopsy to developing carcinoma was so short that it probably was a missed carcinoma to begin with. So that can obscure your statistics in terms of upgrade. So in the absence of any other indication for excision, the data pretty support that the observation of radiological concordant, and I'll emphasize that, radiological concordant benign papillomas or papillomas, incidental papillomas less than 2 millimeter, so-called micropapillomas, that could actually be observed. However, we all know in our current practice, many of these papillomas are actually being excised, but they're pretty solid data that some cases of that actually you can safely observe them. Radioscar is it's a difficult diagnosis for the unworried, I would say, for people that don't do that every day for work. It can resemble cancer radiologically, can resemble cancer histologically. This is a classic picture of radial scar. You have this kind of bands of fibrosis with kind of other nodes at the periphery. So for a pathologist who doesn't do breast or starting his career, that it may actually has a lot of pitfalls. So the expected frequency of radial scars on coordinated biopsy, it's actually not well established. Most of the recent cases, it's about 1 to 2% in approximately 16 to 17 year period. That's about the incidence of radial scars you get in coordinated biopsy. So the recent studies with careful radiological correlation they show that actually the upgrade to carcinoma is less than 2% with the radial scar if you get a diagnosis of radial scar on core needle biopsy. So the data suggests that, and then if the radial scar is small, less than 5 millimeters, then the upgrade again is less than 2%. Now, the size of the radial scar is kind of difficult to determine radiologically, difficult to determine pathologically because the periphery is kind of irregular. So some experts recommend excision of radial scars that is more than 10 millimeters. However, others have not observed a correlation between size and upgrade. So in terms of conclusions for radial scar, at this time there is no consensus for management of radial scars identified on core needle biopsy. Incidental radial scars, especially those that are less than 5 millimeters, they may actually not require excision. You don't have to go back in all of them. However, larger radial scars and those associated, of course, with atypia, because you can have AD8s and LCIS and things like that, then should be excised. And lastly, a few words about the Mucocele-like lesions. So Mucocele-like lesions are areas of mucin extrusion into the breast stroma, and usually there's an adjacent to a cyst with mucinous context. However, it may actually be detected as a mass, or it may be associated with a calcification that may be present in the mucin or within the cystic spaces. They're not that common, and there are actually no large series with long-term follow-up data defining the cancer risk associated with these lesions. So the major concern, of course, if you get a diagnosis of that on core needle biopsy is this a sample error? Could this actually represent mucinous carcinoma? For this reason, many experts actually recommend excision of Mucocele-like lesions that they're diagnosed on core needle biopsy, regardless if you actually see atypia or not. The data in the literature are pretty conflicting. The upgrade rate is all over the place. Some studies are up to 30%, but again, these are not good radiological pathological correlation. But actually, if you exclude, in the studies that they have a very good radiological pathological correlation, and you exclude Mucocele-like lesions with atypia, you take them out of the equation because this will need excision anyway. Actually, the rate is very low. It's actually less than 1%. So if you have a Mucocele-like lesion with no atypia and good radiological pathological correlation, the rate is extremely low. So the likelihood of underestimation of malignancy actually may be higher in patients who have palpable or symptomatic masses and limited sampling with core needle biopsy. Common sense here. But if you have a Mucocele-like lesion that is radiologically concordant and there is no atypia, you may actually safely observe these lesions with a low threshold for excision if there is any should any changes in the radiographic appearance happen. So the recommendation after radiological pathological correlation, AD8s, all patients should be referred for surgical consultation excision. AL8s, some patients with incidental AL8s may actually offer surveillance. LCIS, if you have an incidental classical LCIS, you may be offered surveillance. Patients with non-classical variants should undergo excision. Flat epithelial atypia, most patients offer surveillance, especially if all the residual calcifications have been removed. If you have residual calcifications, you need to go back. Papilloma, if you target a papilloma, and it's just a benign, histologically concordant, a small benign solitary papilloma or a small incidental papilloma, you may actually observe, but the reality is most of them have been excised. If you have an incidental radial scar, that there's no atypia, there's no AD8s, AL8s, and things like that, you may actually safely observe this lesion. But if you have a large radial scar or targeted, which is targeted, then it should be referred for surgical consultation. And then Mucocele-like lesions that you don't have any atypia may actually safely be observed as well. So we should not take excisional specimens lightly. I mean, even the core needle biopsy is kind of an ordeal for patients, psychological and so on and so forth. So the accumulation data from core needle biopsy studies that I cannot overemphasize this, that have a good, careful radiological pathological correlation, suggests that not all patients with atypia, actually benign papilloma, radial scar, or Mucocele-like lesion require surgery. And we should always be aware that the impact of core needle biopsy diagnosis of these non-malignant breast lesions and the ongoing interventions in patients' lives are actually often overlooked by busy clinicians. Thank you very much.